So we can start.
Okay. Good morning, good afternoon, and good evening to all the participants and respected faculties from all over the world. So today we have under the aegis of Mumbai Hematology Group on myeloma an update from ASH December 2025 update. So we have, in order to keep the ball rolling, we have a distinguished moderator, Dr. Amit Khurana sir. Sir is having a fellowship in bone marrow transplant, did his fellowship in hematology, as well as in clinical hematology. Sir is practicing as hemato-oncologist based at Surat, Gujarat, India. Sir is highly skilled and experienced as a hemato-oncologist with more than a decade of experience in the field. Sir, as I said, Sir has a fellowship in bone marrow transplant, hematology, clinical hematology, and is an expert in managing hematological and hemato-oncological patients. Sir has extensive experience in both autologous as well as allogenic stem cell transplant. So, Sir gives us pivotal information for stem cell transplant and the drugs. With that, in order to keep it, I request Dr. Amit Khurana, sir. Please kindly introduce the speaker, sir. Sir, please.
Thank you, Mr. Somnath. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is no other than Dr. Ajay Chari from San Francisco, California, and he's going to lecture us on myeloma, an update from ASH, December 2025. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Jensen Jensen, Intas, Unipath, Lucien, and Netco, and very well managed by Perfect Square. I thank Team Jensen Jensen, Entas, Unipath, Lucien, and Netco, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Ajay Chari from San Francisco, California, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 11th of January 2026 from 11:30 am Indian Standard Time, we have Dr. Gaurav Prakash from PJ Chandikar speaking to us on venetoclax in AMM acute myeloid leukemia induction therapy, current evidence and evolving perspectives. Let me introduce our discussions for the day, and they're well displayed here in alphabetical order. I will pause for a while for you to look at all our discussions for the day for very eminent hematologist, hemato-oncologist, as well as medical oncologist all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We are no other than Dr. Ajay Chari from San Francisco, California. Let me introduce Dr. Ajay Chari to all of you. Dr. Ajay Chari is currently the director of the Multiple Myeloma Program and co-director of clinical research in hematology oncology at the University of California, San Francisco. His research interests include the development of novel chemotherapy regimens, including the phase 1 as well as phase 2 studies. He is a principal investigator of several investigator-initiated trials and serves as the national and international PI of several industry-sponsored studies. He received his undergraduate degree from Stanford University and his medical degree from the David Geffen School of Medicine at University of California, Los Angeles. He completed his residency in internal medicine at Columbia University Medical Center and a fellowship in hematology and oncology at the University of California, San Francisco. As of this fall, Dr. Cherry will be returning to UCSF as a director of multiple myeloma at the University of California, San Francisco. Today he's with us and is going to lecture us on myeloma and update from ASH December 2025. Well, thank you so much. I stop over here. Over to you, Dr. Ajay Chari.
Thank you so much, Dr. Khurana. Let me share. Are the slides visible?
Yes, perfect.
Okay, great. It's a pleasure to be here. I remember my visit to Mumbai not too long ago, and actually it's been, I think, a couple of years already. So my move to UCSF was in 2023. But this year was really exciting. I think for myeloma at ASH, we had not only usual quality of abstracts, but there were two late-breaking abstracts that were presented. So briefly, I'll start with newly diagnosed myeloma, and then some updates on CAR-Ts and updates on bispecifics. So this is our table of agents that many of us have access to. I think obviously global variation, but we have historically the steroids, conventional chemo, but now 3 IMiDs, 3 PIs, the XPO inhibitor, and the really explosion in immunotherapy, right? And it's remarkable that even though myeloma is needed to make every monoclonal antibody, and that was the Nobel Prize in the 1980s for fusing a myeloma cell with a spleen cell in a mouse, we didn't get an antibody till 2015. So we had the naked antibodies targeting CD38, CS1, and then now we have an antibody drug conjugate target with BCMA and belantamab, GPRC5D, talquetamab, BCMA bispecific, TEC, ELRA, Linvo, and 2 CAR-Ts, ide-cel, cilta-cel, and of course, there's venetoclax is often used off-label. So the question you might ask is, well, with so many drugs and many industry think myeloma is such a competitive market space, why even get involved? So the question one could ask is, are we done? And I think what can help set the stage is when we look at overall survival since 1980, this is a recent publication showing that the median OS has been consistently improving, 24, 37, 62, 103, as time has gone by. But I think there's still a plummeting of the OS. We're not seeing the flat lines like we see in lymphomas, for example. And so we still have work to do. High risk and frail elderly especially don't get to live to multiple relapses. So some of the bispecifics, for example, which are approved in many lines of therapy, how can you get somebody who's very high risk or frail to a 4th relapse? And so we really need early use of efficacious regimens to achieve remission and then sustain them. And so I think this schema I'm going to show you going forward for all the studies, and this just sets the landscape for newly diagnosed myeloma. And what I'm showing you in these slides in the formatting is first you have the clinical trials. These are typically the phase 3 studies. So the first 2 IFM and determination were RVD with or without transplant. Forte was KRD with or without transplant. And at the bottom, there's different numbers of cycles. If you're not doing transplant, it's anywhere from 6 to 12 months of chemotherapy. And the median PFS is shown here in blue. And then the hazard ratio, PFS improvement, is shown at the top. And so you can see in all of these studies, even though triplet therapies are quite effective, the addition of transplant yielded somewhere between 35 to 50% improvement in PFS. And so with triplets, it doesn't seem like transplants have gone away. What about quadruplets? We have Cassiopeia, Griffin with DVTD, DVRD, Perseus DVRD, and GMMG7 also VRD with ESA. And so now with the addition of CD38 to the triplet backbones, we don't have medians reached for a lot of these studies, which speaks to the efficacy. They all had about 5 to 6 months of chemotherapy induction and also consolidation. And they all still showed PFS improvement, 30 to 60%. But I think the question that these studies don't answer, they say, okay, quadruplets are better than triplets. But the question is, do we still need transplants? And the MIDAS study is the first study, which is an academic study looking at ESA KRD versus transplant. So if you're doing a quadruplet therapy, do you still need to do transplant? And so far, we just have MRD results, which were not statistically significantly different. And of course, I think the use of MRD should be applauded because if your PFSs are now projected PFS, some people say for Perseus, this can be as high as 17 years. I'm not sure it's quite that high, but it's definitely on the order of probably over a decade. Well, then how are you going to improve upon a decade? And I think the MRD is where that can help. So we'll need to see if there's a difference in these 2 arms. Currently, they're not. But I think just a cautionary tale that if you don't do transplant, you're still looking at 12 months of chemotherapy. So then the question is, with this landscape for newly diagnosed myeloma, what did we learn at ASH? Well, there was a study that some people were quite excited about called COBRA, phase 3. This is KRD versus VRD. It's not a quadruplet, so it's just triplet versus triplet. But I want to call your attention to the study design. So newly diagnosed non-frail patients who are randomized to either KRD or VRD. The VRD was given for 8 21-day cycles. The KRD, however, was continued for almost 2 years. So already seems to be a significant difference in the PI exposure. The RD continues in the VRD arm, and then there's len maintenance. The co-primary endpoints were MRD negative CRs at 12 months and PFS, and then the secondary endpoints are listed. And you could ask, why do this study design? Probably the investigators thought that it's hard to give twice weekly bortezomib for a long period of time. Meanwhile, carfilzomib was given weekly. So it's a little bit another difference is comparing the schedule. So 125 patients were randomized to each arm, kind of typical characteristics of age, 60s, ISS 3/4, good performance status, high risk was about a quarter of patients, and a median follow-up of 35 months. Efficacy, both the co-primary endpoints were met. The MRD negative CRs at 12 months were 31 versus 18%, and the PFS was hazard ratio 0.57, statistically significantly different. In terms of the other endpoints, ORR was similar, CR slightly better, 71 versus 53, 10 to the minus 6, MRD negativity, 19 versus 7%. Safety, comparable deaths, AE grade 3, 72 versus 62, the neutropenia, 21 versus 11%. And then infections, most common non-heme AE was in lower respiratory, 10%. As you might guess, neuropathy, 17% for KRD versus 56% for VRD. Cardiac events, 18 and 10% respectively for KRD, VRD. So how do we put this into the context? And I think, carfilzomib is a very important drug, but we have to remember that it has not always been a positive phase 3 study readout. So Endeavor, KD versus VD, Aspire, KRD versus RD, Candor and IKEMA were CD38 KDs versus KD doublets. These 4 studies all had PFS benefits, some had OS benefit. These are approved. But there are also 3 studies that did not meet the endpoints. Focus was a relapse refractory study, carfilzomib versus steroids and cyclophosphamide. Endurance, KRD versus VRD, similar to our current study design. And Clarion, which was newly diagnosed transplant ineligible, KMP versus VMP, and these were not significant. So while carfilzomib is a great drug, and particularly I think the CD38 KDs are notable for PFSs of almost 3 years, it's important to remember that carfilzomib is a complicated drug that, depending on what disease stage you're doing, newly diagnosed versus relapsed, and what partner drugs you're using, what patient population you're using, you can see differing results. Now, going specifically to COBRA, we see that the Velcade was given for 168 days versus carfilzomib 365 days. So I don't think anybody is surprised that you're seeing better results with more PI exposure. But that doesn't answer the question of if you're using it just for induction and consolidation, which should you do? And I would remind people that in endurance, which was standard risk only, you could not have had high risk. There was no difference in outcome. And in myeloma, there's yet to be a drug that worked somehow better in high risk, but not also standard risk. So what do I do in my practice? I usually use DVRD induction unless there's a baseline peripheral neuropathy or there's treatment emergent neuropathy. I certainly switch from V to K. And finally, if there's a suboptimal response, then I often think about switching as well. And one caution is that if you're using KRD, think about using a NOAC over aspirin because the risk of cardiopulmonary and thrombotic events is even higher when you combine carfilzomib with lenalidomide. Okay. Next, let's look at, if you're using quadruplets, who are the newly diagnosed patients now that we worried about? I just told you that some of the projected data for Perseus are 10 months to over up to as high as 10 to 17 years. So who are the patients that don't do well? Who are the patients that are getting less than VGPR or early progression? Jonathan Kaufman presented a retrospective study and found that about 1 in 6 patients failed to achieve VGPR after induction. They looked at about 300 patients that got quadruplet induction, both in Emory and in Greece, and found that the strongest risk factors to fail to achieve VGPR or with the induction are the presence of translocation 1114 and deletion 17p. As you might guess, the PFS was negatively impacted by failure to achieve a VGPR, but OS was not. And in part, likely because the OS of translocation 1114, which was one of the major contributors, was not adversely, they have a lot of salvage options. The deletion 17p patients had both decreased PFS and OS, and that was further exacerbated by the inability to achieve a VGPR. And so the authors conclude here that if you have a suboptimal response to quadruplet induction therapy, maybe we should consider a change to overcome the poor prognosis. Now, another study that I thought was very interesting, this is presented by Luciana Costa et al. With another multi-center retrospective study, was to redefine the functional high risk in myeloma in the context of quadruplet therapy and transplant. So if we keep adding drugs, can we use the same kind of historic cut points as, functional high risk is if you relapse within a year or 18 months, what's the right cut point? So they looked at 312 patients who got quad induction and transplant. The median age was 62. 15% had 2 or more high-risk cytogenetic abnormalities, and the median duration of follow-up was 41.5 months. And of this patient population, 64 patients had disease progression. And then they used different cut points, 4 different cut points for functional high risk, 12 months, 18 months, 24 months, and 36 months. And the proportion of patients that fell into these categories ranged from 3.6 to 16.5%. What is the median PFS after this first line of therapy? It's quite surprisingly and dismally short, 3 months to 6 months, essentially, for the 4 cohorts. And the median overall survival for this population, about 10 months, 9 months, 12 months, and 18 months. Importantly, there were no differences amongst the 4 groups of patient and disease characteristics. Disease progression within 36 months was associated with a reduced second PFS, so hazard ratio of 3, and overall survival hazard ratio of 6. And I think this is the very important, exciting point that if patients got T-cell redirection therapy, their median PFS was not reached, versus those who did not was 6.64 months. In 12 months, second PFS was 90% versus 23% for T-cell redirection therapy. And in multivariable analysis, the use of T-cell redirection therapy in the next line was associated with significantly improved PFS, hazard ratio 0.12, even when adjusting for functional high risk. So I think this just tells us that, even though we're not getting plateaus in everybody, we have tools now that hopefully will improve the outcomes of these suboptimal responders. Moving now to the non-transplant group, we have historically VRD versus RD, RVD light, and Maya, all of which were beneficial, hazard ratio 25 to 45% improvement in PFS. RVD light, of course, was a single-arm study. Now, SWOG, we should note, was not the intent for transplant, so it's really a younger population. In fact, the bortezomib was given IV twice weekly, and the OS benefit was not significant for the older patient, probably because of the bortezomib dosing. The French also presented data that if you're using CD38-RD, maybe you don't need to give DEX forever. So they only gave DEX for 8 weeks. Unfortunately, we only have response rates and MRD negativity, but either looking better or comparable for the Dara-Len without the prolonged dexamethasone. So quadruplets, of course, are very exciting. IMROS and benefit, ESA-VRD, and Cepheus with Dara-VRD. These were all in 70 plus and Alcyon, Dara-VMP versus VMP. Now, again, all of these are showing that the experimental arm are doing better, 40 to 60% improvement. But again, the bortezomib was given twice weekly in both IMROS and Cepheus. So, and Alcyon was given twice weekly for the first month and then thereafter. So I think the real question is, what about a less dose-intense bortezomib-like benefit, which was weekly? Here we have MRD negativity showing better results with the quad versus triplet, but it's still 18 months of a PI, which I think is quite a long time, especially when, let's say, your dosing of the CD38 is either weekly, every other week, or monthly in the long term. Some OS data. So that's kind of the current landscape. Now, I'll ask you to remember these numbers and think about some of the data that we'll be showing you with the T cell redirection in this population coming up. So we've been talking a lot about conventional drugs, but of course, a lot of interest in immunotherapy and particularly T cell redirection. And there's three antigens that have probably been the furthest along. BCMA likely the furthest, followed by GPRC and FcRH5, with cevostamab, a lot of interest, but not yet approved. So to set the stage for the T cell redirection, historically, POM, carfilzomib, DARA, and CELI all have a response rate of a strikingly similar 30% and strikingly similar PFS as monotherapy. What about the more recently approved therapy? Bispecifics, we're looking at 60 to 70% response rate, PFS 11 to 17 months, and then the CAR Ts 80 to 100% essentially with PFS of 1 to 3 years. The problem though is that these are 4+ lines of therapy, triple class exposed, but T cell redirection and ADC naive. So these are important clearly for the advancement of advanced myeloma, but what about less heavily treated patients? Well, the phase 3 studies that have been done to move these to slightly earlier are shown here. We have Icaria and Apollo, which are CD38 Pomdex versus the doublet. Karma and Cartitude-4 are ide-cel and cilta-cel with standard of care comparator arms. Candor and Ikemia, CD38 KD versus the doublets. And Dream 7 and 8, Bella VD versus DVD, and Bella PD versus PVD. So first, I think to call your attention to the study design is we're finally seeing with Bella, for example, triplet versus triplet, and also in the Karma and Cartitude-4, the comparator arms can be triplets. So we're moving away from 3 versus 2 drugs like the CD38, POM, and carfilzomib study. So that should be commended. All the experimental arms here were statistically significantly better. The hazard ratios ranged from about 40% improvement to 71% improvement. So Cartitude-4, a notable standout for the improvement. And then the overall survival, some of these have translated into overall survival benefit. Even both Cartitude-4 and Dream 7 have shown OS benefit. And so some of the exciting data updates for ASH were from the Cartitude studies. So we know that there's a PFS benefit for Cartitude-4, but when you break it down by risk status, you can see that when you compare it to SOC to cilta-cel, the worst group of all was the high-risk group with standard of care, followed by standard risk genetics who got standard of care. And then interestingly, high-risk cilta-cel did better than even standard risk. And finally, standard risk cilta-cel did the best. And those similar trends follow with overall survival, but perhaps not even as much of a difference between standard and high risk, which is nice to see for the still high risk population. So Luciano Costa presented at this year's ASH meeting, the standard risk population, is there a plateau here? So going to my initial question of like, are we getting to plateaus and cures for myeloma? They looked at survival outcomes for patients with standard risk cytogenetics were progression-free and alive at 1 year, and found that if you're in this group, your PFS was 93% relapse-free and OS 93.7% relapse-free. And so I think this is encouraging, showing that if you give cilta-cel to standard risk patients, you can get very durable remissions and maybe a hint of a plateau. My only pushback to the authors is that this premise, who were progression-free and alive at 1 year, is really not a fair analysis. Call your attention to the overall survival curve of standard risk here. In this first year, you do have a drop-off, right? And so it's basically saying if you're lucky enough to get to 1 year without dying, then you're good. But I think, how do you know you're not in that group of patients that's going to die? And I think that's the challenge. I'm not convinced that with this data set that we should be doing this in all standard risk patients, because unless I have a biomarker to tell me who's not going to die, why would I want a standard risk patient to be dead when I have so many other options? Certainly for high risk, it's a different calculus. And in fact, you can see maybe even that the hint that the high risk dotted curve is closer there than the standard risk. And so I think, again, we should be calling our attention to the shape of these curves, right? Do you have a drop off or is it flat from the get-go? Because on the one hand, we're saying that cilta-cel gives you 98% response rate. On the other hand, you have to be alive and healthy enough to get there because otherwise your PFS and OS are not flat. Now, what about the opposite? What about high risk? Well, just a reminder that JCO publication in 2025, updating genomic definition of high risk, was basically deletion 17p in at least 40% of cells, biallelic P1 deletion 1p, high beta 2M with normal creatinine, and TP53 mutation. This is by next-gen sequencing, not by FISH. There was no variant allele frequency given there. And then double hit, which is 14 translocations with a gain of or amplification of 1q or monoallelic. So just one of the chromosomal abnormalities is not considered high risk. You needed to have a second hit. So either a 14 translocation or a second 1q, 1p abnormality. So when we look at the cilta-cel data set, this is from a retrospective data set presented by Doris Hansen to look for predictors of early relapse. And you look at kind of three different buckets. The adapted IMS IMWG high risk, they had 132 patients with that. Functional high risk, which is we talked about, early relapse post frontline therapy. And then you have extramedullary disease. So first thing to call your attention to is these three definitions of risk are independent. There is some overlap of functional high risk and high risk. There is some overlap of EMD and functional high risk, and of course, high risk and EMD. Very few patients have all three. But when you look at these different variables as PFS predictors, all of them showed worse prognosis for functional high risk, genomic, EMD, all had a hazard ratio that favored earlier progression. Prior BCMA therapy and poor performance status did as well. Ferritin, not quite statistically significant. Now, if you ask the question, who are the patients with cilta-cel that relapse within 18 months? So they're not getting to the longer term plateaus. You basically see that all of the risk factors are still there except ferritin, but now EMD is not there. So I think when you put these two together, EMD, of course, statistically is going to give you worse PFS, but not necessarily relapsing within a year and a half. So some of these EMD patients actually can do quite well. And in fact, that's what we've seen here in CARTITUDE-1. So another data set, and this, to remind you, this has been published in JCO. When you look at the CARTITUDE cilta-cel, one of the questions is, when should we be using it? It was initially approved in heavily treated patients, median of 5 lines of therapy. But when you look at CARTITUDE-1, patients who got it in at least 3 lines of therapy, their PFS was about 3 years. If you look at it in patients who had exactly 3 lines of therapy, that's based on CARTITUDE-1 as well as CARTITUDE-4. Now you're looking at 34 patients who have median PFS of 50 months. And if you look at CARTITUDE-4 and 1 to 3 lines of therapy, median follow-up not reached, median PFS not reached with a follow-up of 34 months. And you can see this here that as you move up, the curves seem to keep getting better. So CARTITUDE-1, 4 or more lines versus 3 lines of therapy versus 2 lines versus 1 line, it keeps trending higher. Although we should mention, as I alluded to, even in these heavily treated patients, CARTITUDE-1, there does seem to be a plateau, and a third of patients are progression-free at 5 years, including some who were high risk in EMD. But these patients unifyingly tended to have lower disease burden. So maybe that's what we need to do, is for more heavily treated patients, really very intentional about bridging therapy to make sure that their disease is debulked. Now, one of the questions asked is, what are the biomarkers? Are there data to explain why your PFS might be better on this previous graph? Why are the less heavily treated patients getting better PFS? Is that just statistical variability? Is it disease biology? Is there something about the immune system? And so in this analysis, they looked at gene expression. And in the top part of the graph, patients were divided in black to patients who had a PFS of more than 18 months and red PFS who had less than 18 months. And what they found was that when you compare the early progressors, The early progressors in red had more Tregs, suggestive of a more suppressive immune environment. They have more of this epithelial to mesenchymal transition signature and a PI3K AKT pathway upregulation, suggestive of a more hostile tumor microenvironment. And so when you apply this, these same three signatures, Treg, the epithelial mesenchymal transition, and the AKT3 pathway, to one line of therapy versus 3 or more lines of therapy, you see the same theme. So the heavily treated patients, more lines of therapy, have more Tregs, more of this EMT signature, more of this AKT pathway signature. So perhaps this is one of the reasons why earlier therapy gives you a better outcome, is because you have a more immunocompetent microenvironment. What about the T cell health? When you look at PFS by CD4 naive cells, higher CD4 naive cells in red has a better PFS than lower CD4. And when you look at the CD4 population by lines of therapy, 1, 2, 3 to 4, and more than 5, there's a consistent drop off in the CD4 health. So I think these data sets presented by Samir Parikh, my former colleague at Mount Sinai, more immunocompetent environment supports more durable CAR T responses. So these higher CD4 counts in peripheral blood indicative of human immune fitness, and also the gene expression of anti-tumor myeloid and T cell activation are indicative of an immune-engaged tumor microenvironment. Now, before we leave CAR T, a really exciting data set from ASH was this presented by Joy Ho from Australia, a late-breaking abstract from Colonia Therapeutics, KLN 1010, a new paradigm for in vivo CAR T. So this is a really exciting advancement, and I think for many parts of the world will be very important to have available for our patients. So they took CD3 targeted lentiviral vector, but what they did is they took away the fusogen VSVG. So what this does is it generates BCMA CAR T in vivo. The T cell targeting with CD3, as is often done, and the CAR molecule has a BCMA targeting with 4-1BB and CD3 zeta domain. But when you give this lentiviral vector that's been detargeted from this VZVG mutation, it's T cell specific. So it avoids liver uptake. Very importantly, you can give this infusion without lymphodepletion, without apheresis, without ex vivo manufacturing for each patient. And so basically, it's converting CAR T from a very expensive personalized therapy to an off-the-shelf product. So greatly simplifies logistics, cost, and potentially outpatient feasibility as well. So what are the data that were presented? Only 4 patients, but I think the reason it got this late-breaking presentation is just how much paradigm shift this would be for the world to be moving to in vivo CAR Ts. So phase 1 dose escalation, dose level -1 and 1, relapsed refractory myeloma, 3 prior lines of therapy, and good performance status. So pharmacodynamic data are presented on the right. So with the first 3 patients in the first cohort, there was strong CAR T expansion. Keep, again, reminding that there's no lymphodepletion, no fludarabine cyclophosphamide, which perhaps can mitigate some of the infection things that we see with BCMA CAR T. The peak expansion was day 15. There was a persistent memory cell phenotype that was maintained throughout the CAR T through month 3. And importantly, the vector copy was comparable to approved CAR T therapeutics, so Cmax. Safety-wise, no ICANS, no delayed neurotoxicity. CRS was grade 1 to 2 only. Median onset was day 10. Duration 5.5 days. Minimal cytopenias. Again, no fludarabine cyclophosphamide. 1 transient grade 4 neutropenia. And the infusion-related reactions were manageable with standard supportive care. There was some dexamethasone given because of the robust absolute lymphocyte increase. So how did it do? All 4 patients achieved MRD negativity at 10 to the -6 for the first 3, and the 4th patient 10 to the -5. They've all achieved CRs, or VGPRs, or PRs. Those responses, as we know, can deepen. You can see that the light chains, as with many CAR Ts, the light chains clear very quickly, but the M spikes can linger, and that's what sometimes causes us to undercode the depth of response. So lingering M spike, of course, making somebody unable to be a CR. And in fact, you can see the purple patient is the one who became the CR with the clearance of the M spike. The red and green patients are lagging a little bit. Soluble BCMA also goes down, showing proof of concept. So I think really exciting data, and hopefully will be more the modality of therapy. Because if you can get CAR T efficacy with bispecific convenience, wouldn't that be a winner for all of our patients? And that's a good segue to bispecifics. So as we know, bispecifics have a myeloma antigen binding and T cell binding antigen component. And then when these bispecifics are brought in proximity to both the T cell and the myeloma cell, you have a release of pro-inflammatory cytokines that kill the myeloma, off-the-shelf product. And so when we look at cancer therapies with bispecifics, it's a rapid expansion. You can see myeloma now has 4 approved bispecifics in the US, and then many other diseases also. So I would argue these are the new monoclonal antibodies, and here to say. I think particularly right now, we're seeing a preponderance of heme malignancies, but we do have lung cancer, melanoma, lymphoma. So I think the wave is going to be continuing. And once solid oncology has more bispecific approvals, some exciting data for prostate cancer, for example, we're going to see that I think there will be even more community uptake for these products. So to level set, we have the 3 BCMA bispecifics, TEC, Elra, Linvo. I know that you all have access to TEC now, which is great. Some of the initial studies, 5 lines of therapy, significant triple class refractory. We're seeing responses of 60 to 70%, PFS of 1 year to 1.5 years, very durable responses. I would caution from single-arm cross-study comparisons of these PFS, particularly when teclistamab was the first to market and was the most affected by COVID, most affected by not knowing about the importance of IVIG prophylaxis. And of course, talquetamab, I believe you guys are getting soon. 2 approved doses weekly every 2 weeks. Similar population, similar responses of 70 to 74%. PFS, 11.2 months. This is why we're using the every 2-week dosing, less frequent, with seemingly better PFS and DOR, perhaps due to less T-cell co-exhaustion. And of course, some important differences amongst the bispecifics. In the BCMA, TEC is the only one that's weight-based. TEC and Elra are pretty closely stacked step-up, but Linvo has weekly step-up. And then the timing of going to bi-weekly and every 8 weeks is slightly variable across the products. Talquetamab also milligrams per kilo, and the bispecific remains every 2 weeks. But let's go into a little bit more of the exciting data that's coming out. And to set the stage for this, teclistamab as monotherapy, as I said, has a response rate of 63%. In Dara-Len-Dex Majestic-2, we're seeing now in 2 lines of therapy, 94%. TEC-Len Majestic-5, this is given for 6 months pre-transplant. We're seeing 100% MRD negativity, 90% response rate. TEC-Len as consolidation post-transplant, 100% MRD negativity, 90% CR. And in smoldering myeloma, 100% response rate, 100% MRD negativity. And I show you this because, we talk about primary refractory disease versus secondary. Primary means not everybody's responding, but it appears that as you move the product earlier, that primary refractoriness seems to diminish. Now, admittedly, the smoldering myeloma data set is only 10 patients, so we can't overstate that, but there's definitely seems to be better outcomes with T-cell redirection. As we saw even with the cilta-cel data set, you have better, more immunocompetent T-cell microenvironment and more CD4 cells. So all of these translate into better outcomes. And the question that is being asked is, well, what about in 1 to 3 lines of therapy now? And can we finally get some phase 3 data? And fortunately, I know you've all heard about this, but there was a late-breaking abstract at ASH presented by Mari V. Mateos, which was a parallel New England paper, first author Costa, talking about Majestic-3. So what is this study design? 1 to 3 lines of therapy, including a prior IMiD and PI. Patients with only 1 prior line of therapy had to be lenalidomide refractory. They had to have good performance status. And very important, you could not have had prior BCMA therapy, and you could not have be refractory to CD38. This is a big issue because if we believe the Maya and Cepheus and IMRA's data set, where CD38 frontline is really exciting and leading to PFS and OS benefits, those patients, when they progress, technically would not be eligible for this study. So this was not refractory. If you had exposure, that was allowed, but it was only about 5% of patients. So it was a 1-to-1 randomization of Tec-Dara versus the standard of care options were DPD or DVD. 91% of patients pick the DPD. And then the primary endpoint was PFS. The usual secondary endpoints, CR, response, MRD negativity, OS, symptom score. So the dosing of Tec is also different than monotherapy. So you have your step-up doses, then you get weekly for the first 2 months. And so this synchronizes with the Dara weekly schedule. But after that, Tec goes to every other week starting month 3, and then goes to monthly dosing at month 7. So in other words, Tec aligns with the Dara schedule. And then also important, this is a doublet. There's no steroid after cycle 1, day 8. So after you finish your step-ups, there's no more steroid. So the response rate, 89 versus 75%, CR rates, 82 versus 23, odds ratio 9.5, DOR 86 versus 36%, MRD negativity, 58 versus 17%, but in MRD evaluable CRs, 90% MRD negative with the doublet. And what it was really, I think, the most striking was the primary endpoint of PFS. We have 83% progression-free at 3 years versus 30%, and the hazard ratio 0.17, which is probably the single best hazard ratio we've had in a phase 3 study in myeloma. This is over 80% improvement in the likelihood of progression or death. And what's also striking is this apparent plateau, right? The curves do take a little bit of time to separate, but then this basically looks flat. And when you look at subgroup analysis in the forest plot, was there any characteristic that did not favor the doublet Tec-Dara versus the triplet standard of care? Age, prior CD38, again, very small number, refractory to len, ECOG, investigator choice of which regimen, prior lines of therapy, ISS stage, even ISS3, which is often unmet need, had a benefit, hazard ratio 0.31. EMD, 0.33, high risk, 0.15, heavy marrow burden, 0.17. So really showing the striking benefit of the combination, T-cell redirection combination. What about overall survival? Now, we often say in relapsed myeloma, you need longer follow-up, OS is trending favorably, but look at these results. Already hazard ratio 0.46, so almost 50% improvement in the likelihood of progression or death, 83% versus 65%. And again, when you look at the forest plot, all the subgroups, including older patients, which I think is important because of the safety issues that we can see with BCMA bispecifics and infection, maybe ISS3, high risk, and EMD, not the high risk seemingly benefiting still from OS, but there's maybe smaller numbers giving smaller, wider confidence intervals, trending better, but for ISS3 and EMD crossing 1, and heavy marrow burden also statistically significant. So all great, but I want to call your attention to the beginning of this curve. Again, we have a highly efficacious product where patients are responding, very durable, but why is it that the red curve is actually below the black curve initially? And there's a delay in the crossover to see improvement. And I think this goes to the safety issues. So 71% of patients remain on treatment versus 28 for the 2 arms. Median duration of treatment, 32 versus 16 months. And 95% of patients remain on Tec-Dara. The safety profile, CRS 60%, mainly grade 1, 2, no grade 3, all resolved. ICANS, very low, all resolved. Treatment related to AE discontinuation, low, about 5% in both arms. SAEs 71 versus 62. Deaths due to SAEs 7.1 versus 5.9%. And the main question, of course, is the infection signal. What is the infection signal of this combination? Because you're targeting both CD38 and BCMA. So all grade infections, 96 versus 84. Grade 3, 54 versus 43%. And COVID is a big issue because this was started during the COVID pandemic. So COVID-19, 44% versus 33%, high grade 6 versus 2, upper respiratory, similar patterns, and COVID-19 pneumonia, is where we see this difference to 12 versus 4%, 11.3 and 2.4. UTIs, we don't see as commonly and not as different. And so I think what's important here when we look at the infection is that because the study started during the pandemic and before bispecific guidelines of IVIG and antimicrobial prophylaxis, there were 5% of deaths due to infection. 12 occurred within the first 6 months of therapy. And so that's that crossover that I showed you in the previous graph. 3 of those were due to COVID, and 9 of those 12 deaths didn't receive immunoglobulin replacement therapy. And so subsequently, there was an amendment in February of 23 to reinforce that and also recommend antimicrobial prophylaxis. And with this, you can see that the rates of grade 3 infections diminished over time. And this probably correlates with the plateau that we saw. My only caveat to this is anytime you're seeing the AE getting better with time, we have to keep in mind, is it really that the AE gets better, or is it that the physicians and teams have figured out how to treat the patients, adjust the dose, and unfortunately, the people who've died have already died, right? So it's I think I'd always take this with a cautionary tale, but I think it's good to see, of course, that you're not seeing new infections going up later, but certainly the decrease is confounded by some of those things. Now, the question is, especially while this data looks amazing, many younger patients may still want to do CAR T because we know that if you do bispecific first, your CAR T will be compromised. Whereas if you do a CAR T first, you can still get some mileage out of bispecific, but although you often need to switch target. But then the question becomes, this kind of Majestic-3 data might be preferentially used in older patients, right? And the challenge there with the older patients is first, of course, as I mentioned, they're more CD38 refractory, but are we sure about the safety profile of this older population? And I think probably in some ways even more compelling than the Majestic-3 was the TECLEAL data. Now, this is a phase 2 study with only about 37 patients, but this is French data set. And cohort A was TEC-DARA in transplant-eligible, newly diagnosed myeloma, age greater than 65. So the median age was 73. So these are older patients, and a third of them were even older than 75. One thing they did differently, they go to monthly TEC after cycle 2. So maybe you don't need that weekly for the 2 months of teclistamab, where the DARA was standard schedule. The primary endpoint is VGPR greater than 4 cycles, which was 79%. Best response, though, was 100%. VGPR and better, 100%. MRD negativity, 73% intention treat. But if you look at evaluable patients, 100. So 100, 100, 100. And most striking, look at the PFS and OS curves, also 100. So it's hard to get flatter than this. So I set the stage earlier in this slide. My first slide was the lack of plateaus, and look at the results that we're seeing. And so one of the important things, though, is, okay, so the efficacy is great, but how did these patients do safety-wise? Well, dose intensity was maintained, 95 to 97% for both products. Grade 3 infections, only 14%. Now, of course, the median follow-up is only about 10 months, but 14% systematic IVIG. They did look at CMV viremia to see if CMV is reactivated, and I think they did see it in about 8%. The discontinuation was only 3%. There was a patient with GI salmonella, and you can see the AEs here on the right. The most common heme AEs were lymphopenia and neutropenia. Non-heme, as I mentioned, 5 patients, so 14%. But when you look at all grade infections, it was 65% grade 2 and higher, 52. Grade 1 and 2, 52%, grade 3 and higher, only 14%. Relatively fewer COVIDs, pretty much just one of these various infections. CRS, I think, quite favorable as you might expect. And I think the other important thing here is that you can see the cumulative rate of infection seems to, again, be like kind of leveling off, but again, shorter follow-up with small groups of patients. And the other very important finding, which we've also studied and presented on, is that if you get a BCMA-directed therapy, your IgG level will go down to essentially 0 very promptly. So I think it's really important to highlight, and in some ways, maybe we shouldn't call these doublet therapies. TEC-DARA, I would argue, should probably be called a triplet. every patient should get an immunoglobulin replacement. Otherwise, you're going to get that OS crossover issue. So I think this data really complements nicely Majestic 3. So one other bispecific antibody I thought that was very interesting, which is called Limitech. And this is a prospective study of fixed duration teclistamab for relapsed refractory myeloma. So in this study, patients got teclistamab, and then if they got 6 to 9 months of therapy, then they would stop the therapy. So limited duration of teclistamab. And then if they were followed on this study and they remained negative, then they would get, I think the coding came off. If they remained relapse-free, then they kept staying on observation. If they relapsed, teclistamab would be started and continued until disease progression. And that's if there was off-drug disease growth. So not necessarily meaning full progression, but you see detectable disease again, you could resume. And if you had INWG progression, then you could resume teclistamab. And if 90 days later, if you didn't get an MR better, you would of course come off. Now, first thing we see is by doing limited duration therapy, does it change the infection profile? Does it affect immune surveillance health? And what we can see here on the right is when you look at the uninvolved light chain as a measure of time to recover from the paralysis of BCMA-directed therapy, you only see this improvement starting at 6 months. So prior to that, even though you stop BCMA bispecific, there's no recovery. So it's really important to continue that immunoglobulin beyond the discontinuation of bispecific. CD19 also takes 6 months to start increasing, so it's not rapid. Now, what did we see with the clinical data? The progression-free survival so far is comparable to continuous TEC. Most patients have remained off therapy for 12 months. The potential follow-up has been about a year. 6 months after enrollment, 76% remain relapse-free. 12 months after enrollment, 68%. So the median PFS after enrollment, very impressive, 19.9 months. Overall survival, 90%. And when you look at prior BCMA therapy, 90% remaining, 77% at 12 months. No prior, 72%. So even prior BCMA exposure didn't seem to relapse earlier. CR or less than CR, similarly doing well. What happens when TEC was reinitiated? Well, out of those total population of about 50 patients, 17 did progress. 15 restarted TEC at about 5.5 months after progression or after stopping the teclistamab. And unfortunately, none of the 12 patients who started within 12 months of enrollment responded, and only one of the 3 who restarted after 12 months responded. 6 of the 7 who got talquetamab responded, and 4 patients died all after myeloma progression. So it does seem like fixed duration therapy can be used, but the problem is retreating may not be a viable strategy. And so my concluding slides, I think this is an older data set. So sorry, I think the conclusions are for newly diagnosed patients. We have for transplant eligible patients, we still have quadruplets, and some of the high risk findings are 1114, deletion 17p. Functional high risk, probably if patients relapse within 36 months of a quadruplet, they're in trouble. When we go to the CAR-T, we're seeing great results with CARTITUDE-4 and CARTITUDE-1. Moving CAR-T to earlier is associated with better outcomes, better immune microenvironment, perhaps a plateau, but I still think there's that depth issue early on, so maybe not for standard risk patients. I preferentially use cilta-cel in first relapse in double refractory, so CD38 LEM double refractory, functional high risk, or EMD or genetic high risk, right? Something that makes the patient warrant taking that upfront risk of toxicity and those rare toxicities like delayed motor neurotoxicity, Parkinsonism, colitis, et cetera. And bispecifics, and of course, the in vivo CAR, of course, looking really great, and bispecifics, Majestic 3 really finally giving us a phase 3 readout of TEC-DARA and the TEC-LEAL study highlighting the importance of IVIG or immunoglobulin replacement. And perhaps we don't need to give everybody the current dosing of bispecifics of weekly for a long time and then less frequently. We can perhaps go to monthly faster, perhaps even think about stopping and giving people treatment-free interval, although that doesn't prevent the IVIG from needing to be continued. So with that, just wanted to thank you all for your attention and thank my team at UCSF, and happy to take any questions.
Thank you so much, Dr. Ajay Chari. That was wonderful. Thanks a lot. And I request now all our discussants to please put the hand raise sign so that we can start the question session with Dr. Ajay Chari. Yes, first we have Dr. James Kungar. Please go ahead. So, yeah, so first we have Dr. James Kungar. Please go ahead.
Dr. Ajay Chari,
Yeah.
I just
Hi.
want to ask, in a newly diagnosed case of multiple myeloma, what regime you follow? Whether you follow quadruplet regime or whether you follow triplet regime? What is the current first line therapy scenario?
Yeah, I mean, I think that the slide I showed you, all the quadruplets are showing benefit over triplets, right? Whether it's Cassiopeia, Griffin, Perseus, the isatuximab studies. So I think I do quadruplets for everybody for transplant eligible patients. So I think DVRD for everyone, and then they switch to carfilzomib if they have suboptimal response or neuropathy. I do transplant. I'm not convinced that everybody needs doublet maintenance. I think len maintenance for everybody post-auto, but if you're standard risk MRD negative after an auto, I'm not sure you need the CD38 because they're going to do well with just len alone. And so for anybody who's MRD positive or high risk, I'll continue doublet CD38 len maintenance. In terms of transplant ineligible, I think this is trickier. I do see, of course, the Cepheus and then the CD38 combination IMRAs as well, showing a PFS benefit. But the question I always ask is, who are these, quote, transplant ineligible patients that are getting twice weekly bortezomib for 6 months? I mean, to me, that's a tough regimen. And if you're transplant ineligible, why are you getting twice weekly bortezomib? So I think it really speaks to a very selected fit population that's getting that. And I don't know that, and I think if you go back a second, if Maya, CD30RD alone, is giving a median PFS of 5 years in a median age of 73, why do we need to add PIs for everyone there? Because then you get this neuropathy signal, which is as high as 57%, and some of that is grade 2 and higher. And so I personally, what I do for the transplant ineligible population is I start off with a PI as long as there's no baseline neuropathy, especially if they have high risk EMD types of disease. I'll start off with a PI, but I basically follow the DARA schedule because, again, these older patients, to have them come back to the clinic just for a bortezomib injection is also asking a lot. Do I have data for my approach? No, but I feel like I don't want to torture all my patients with bortezomib for 6 months or even longer until we have data to support that. And the benefit study is the study, because, if you believe Maya is the gold standard, to me, the question is not whether you should add CD38, it's whether you should add PI. So the real question is DRD plus or minus V. And the only study that did that is the benefit study, which is French. But even they gave 18 months of PI. So I personally would do more of a modest PI exposure for the transplant ineligible. So hopefully that answers your question.
Yeah. Okay. Well, thank you so much, sir. Dr. Roshni Pandey, ma'am, your question, please.
Hi, thank you for the updates. I had a couple of basic questions. One is how to approach a newly diagnosed 17p del multiple myeloma.
I think great. It's a good follow-up on the previous discussion. I still do DVRD for these patients. And then if they're not having a good response because del 17p wouldn't do as well, I might switch to DKRD. I still do transplant. I still do 2-drug maintenance. Sometimes I do more consolidation. I don't usually do consolidation post-transplants, but for high risk, if they have residual disease, I'll do the consolidation. and then double drug maintenance. And I think at first sign of relapse, I would go to CAR T. And that's probably the current paradigm. Now, are we ready to go to CAR T or bispecific in frontline? I think we're all excited for that data, but we don't have CARTITUDE 5 and 6, which are looking at frontline CAR T readouts yet. And we don't have the frontline bispecifics readout yet. But I think very soon in the near future, we'll probably have a chemo-free therapy. It'll probably be immune therapy. We may not be using PIs and IMiDs anymore. And we may be moving to CD38 with bispecifics or CAR Ts. So really exciting time.
Okay, I have a patient with light chain nephropathy. He's about 70 years and he's dialysis independent with VCD. Now, how to go about the maintenance part? You can't keep on calling them weekly.
Yeah. Well, first, like my practice, I usually use the DARA as well. So we use DARA VCD. And then if they're fit, it's important that renal failure, of course, is not an exclusion for transplant, right? So we can even do dialysis patients. So certainly you could still do transplant, but reduce the dose likely to MEL 140. And then after transplant, I think you have a couple of choices. Lenalidomide remains the single most efficacious drug, and I think in maintenance, right? It has PFS doubling, right? Median PFS goes from 2 to 4 years with the addition of len, and it confers an overall survival benefit. And I bring that up in the context of your question because I always tell my patients, like, maintenance is a tricky discussion, right? It's almost like antibiotics. Should you take an antibiotic preventatively for the rest of your life, or should you take it when you have an infection? And if you're going to do it preventatively, this is where health authorities, of course, you're going to get a PFS benefit, but you really should ask, are you getting an OS benefit, right? Because at the end of your maintenance, you're making a patient refractory to that drug. And I think for len, we have that data, that doubling of PFS translate into OS. So len resistance is worth it. If you apply that standard to all the other drugs, we don't really have that. Even for CD38, Perseus stops after 2 years. So I don't know that we want all of our patients to be len and CD38 refractory. PIs are not on label technically, but you could do PI maintenance. So for your patient, I would say that you can use len on a renally dosed basis. And it might be as low as 2.5 milligrams daily, right? Not 10, not 5. You could try that because see how the patient does and see how the blood counts do, how the patient tolerates it. If that works, then great. If not, you could either do no maintenance or CD38 maintenance for 2 years, especially if you're having residual disease. But I would not do CD38 till progression. And another option would be to do bortezomib or ixazomib maintenance, right? Because ixazomib is an oral version. So I think you were struggling with how long to bring the patient in for bortezomib. But those would be some of the options that you could play with. And at the end of the day, it's important. The two final things I'll say is the Canadians did an interesting study. Even though lenalidomide maintenance is approved and widely used, it is not well tolerated, right? A lot of patients have fatigue, diarrhea, cytopenias. And the Canadians showed that in their data set, 5 milligrams did just as well as 10 milligrams from the clinical trial. So I think we don't reduce the len often enough for AEs. And I think we can try that more. And then, of course, if it's a standard risk patient, this might be the person to say, you know what, let's not do maintenance. We'll observe you.
And the bortezomib maintenance, should it go bi-weekly or once a month?
I think if you're going to do it, the data sets, when you look at
most of our patients cannot afford DARA. So this is like one such patient.
No, of course. I think that's a real issue. When you look at the PI maintenance data set, it does seem like there's a lot of variability in the outcomes. And I think some of that relates to the dosing intensity. In general, the studies that read out more positive tended to give more PI, and the ones that were more equivocal, less PI. So I think if you're going to do bortezomib, because it's a short half-life, it probably makes more pharmacologic sense to do it twice monthly, every other week, rather than monthly.
And in patients with CKD, young patients, How much do we gain with autologous stem cell transplant as consolidation, and what do we do with their renal, I mean,
Yeah.
how do we approach them as like totally palliative, or what to do with them?
Well, one of the unmet needs today is persistent renal failure, right? So first thing I would say, one of my principles, time is kidney. We have a narrow window of time when you have a newly diagnosed patient with renal failure to recover the renal function. So it really is important to hit the patient hard at that point with quadruplet therapy, modifying for suboptimal response, and trying to take them to transplant to get them to the zero. Again, melphalan, I don't think it's not nephrotoxic, but if you have to give lower dose in renal failure patients. So I don't think anything about the induction and transplant. Probably the biggest difference for induction and transplant is the dosing of lenalidomide and the dosing of MEL. Once you're done with the transplant, then it kind of goes back to the same discussion we just had with your other question about maintenance. But I think if you recover renal function, the prognosis of these patients is identical to non-renally impaired, right? So that's why I bring up the time is kidney issue. And so many patients actually, I've had patients who start off at dialysis, their renal function improves, and they're actually able to come off dialysis, although they don't have normal renal function, which is also very meaningful for a patient, right? So you have a creatinine clearance of 15 to 20, but you're not on dialysis. That's great, right? And so I think we should push to try to get maximal debulking.
And there's a patient who was diagnosed in 2014 or 15. He received VRT. He refused autologous stem cell transplant. He later relapsed on lenalidomide maintenance. Then again received induction with bortezomib-based therapy, went on for autologous stem cell transplantation. The M-band did not come down as such. He was put on maintenance. Then he relapses after that, and he's on Carfil, Pomalyst, and Dexa. Now it's a very difficult schedule to maintain. He's finished about 12 cycles. Now, how to call him day 1, day 2, day 8, day 9, and it just goes on and on. Is there a way to maintain him now?
Yeah, I would probably switch the carfilzomib to once weekly, 56 milligrams per meter squared, so
Yeah.
1/815.
Yeah.
So I don't think we need to do twice weekly. The POM, you could reduce the dose if it's a problem. And the DEX, you don't need anything more than 8 milligrams at this point, right? Because you need antiemetic dosing for the carfilzomib at 56, but you don't need 20 or 40. So you could do CARPOM with 8 milligrams of DEX to maintain the patient. And I think your patient also highlights something that I'm kind of interested in, which is already in the US, you may or may not know this, only 30% of patients who are transplant eligible are getting transplanted. Whether that's because doctors aren't referring, patients aren't choosing to do it. And I think what I'm telling patients is if you don't do transplant, and especially if you're over 70 or very close to 70, if you're not doing it now, what are you waiting for, right? Like, if it's just going to get more difficult with age, performance status, comorbidity. So if you're going to collect, do the transplant as a part of consolidation. And I think my worry is, as your patient kind of is bringing up, as it is, we only get a PFS benefit from transplant. And I worry that that benefit may not be that great in a relapsed patient, because I don't know that melphalan is an amazing drug for somebody who's refractory to your one or two drugs, right? I think, so I worry that we're not using transplant well if we're going to do that. I'm happy to get rid of transplant if it's displaced by CAR T, but I think it's something we all need to think about, which is kind of like this delayed transplant approach. How much are we really helping patients versus just using a product because we committed the patient to collection?
And my last question is, in a patient, say with an M-band of 0.4 grams per deciliter, in evaluation done by the nephrologist, the proteinuria is 4 plus. Should we push for a renal biopsy if the patient is diabetic and hypertensive? The nephrologist says that the ocular examination is normal, so no need for renal biopsy. I mean, you just go ahead and work up for the multiple myeloma and say rule out light chain nephropathy. So do we need to push for a renal biopsy?
Is this very long-standing diabetic and hypertension with very long-standing
2 years.
proteinuria?
2 years. Proteinuria, I'm not sure, probably 6 months.
So I think if it's recent onset blood pressure diabetes and recent onset proteinuria, we should err on the side of being conservative and do the full workup, right? Because now if somebody's been hypertensive diabetic for 20 years and have had nephrotic syndrome for 20 years, that's different than everything happening concurrently. I think if it's happening concurrently, it's incumbent on us to make sure that this patient. Now, one thing you could start with before doing the renal biopsy is do a fat pad biopsy and do a Congo red stain on the marrow,
Yes.
because if either of those are positive, you might presume that this is an amyloid patient and treat
Yes.
them. But if those are both negative, I think it's important to do the renal biopsy, not only for amyloid, but to rule out those other MGRS conditions, right? So those other rarer conditions. And one other thing to do, which I do in all my renal failure patients who have paraprotein, is also to rule out cryoglobulinemia, right? So checking C3, C4, CH50, rheumatoid factor, cryoglobulin, because cryo could be related to the paraprotein and link both conditions as well. So that would be my suggestion.
Thank you so much.
Sure. Great questions.
Thank you, ma'am. We'll take some more questions from the audience because there are lots of questions lined up now. The first question is from Dr. Shyam. Is CAR T cell therapy new standard for the first relapse in multiple myeloma?
I think it depends on the patient. If it's somebody who is not having explosive disease, right? So that's the first thing. If you have really explosive disease, it's hard to even get them to a CAR T. But and they are higher risk. This is my take, because I think if they're higher risk, as I alluded to earlier, whether it's functional high risk, extramedullary disease, genomic high risk, double refractory, the more high risk they are, the more you should use CAR T in first relapse. The more standard risk they are, do you really need to incur that risk of treatment-related mortality, right? So I don't think we talk about that enough. That OS curve for CARTITUDE-4 is not flat. It drops off by almost 10%. If you compare that to an auto transplant, where most studies show the mortality rate is less than 1%, there is probably a 10% mortality rate from cilta-cel. And yes, we've learned a lot and we can probably do better, but I think that's a fact. So that's why I think it's a little bit like playing Russian roulette. If you do it in every patient at first relapse, you're exposing a bunch of standard risk patient to treatment mortality, a non-zero rate of Parkinsonism, probably 1%, up to 9% rate of cranial neuropathy, 1% rate of enterocolitis, and slightly higher rate of secondary malignancy. So I don't know that you want to do that for every patient, but if high risk, absolutely.
True. The question is, what about maintenance therapy post CAR T cell therapy?
You know, one of the most beautiful things about CAR T is the treatment-free interval. So here we are talking about plateaus, and even in CARTITUDE-1, where there were heavily treated patients and a third of those patients were remission-free for over 5 years. So I worry that if we say broad maintenance, we're really, in a way, going backwards. We're making people go back to continuous therapy. You heard one of our panelists ask about maintenance. How long do you have to keep them on it? So I don't think we should be doing maintenance, first of all, on all patients. Number two, we don't even have data on what to use. There were some initial studies, for example, using checkpoint inhibitors, and those have not panned out. I think some people use IMiDs like pomalidomide to try to do maintenance. I think it's reasonable to consider. You saw the data set presented by Doris Hansen here. If you have somebody with those high-risk features, functional high risk, EMD, genomic high risk, and or you're not MRD negative, those might be patients I might do POM in, but I wouldn't do it for every patient because many of them are going to do very well. And the beauty of CAR T is not just response and PFS, but it's the quality of life improvement. And if we're now giving them therapies that's going to diminish that, how are we helping the patient?
Very true. The third question from Dr. Shyam is, will MRD be the goal of treatment for multiple myeloma?
Yeah, it's a good question. The health authorities clearly have approved it as a surrogate endpoint for randomized phase 3 clinical trials, but I want to remind people how MRD is done in clinical trials. So first, you have an SPEP, you have an IFE, you have a light chain, you have a UPEP, urine immunofixation, you have imaging. If all of those are negative, then you're doing a bone marrow for MRD. Many times in the real world, because people transpose, like say from CLL or other diseases, they'll just do MRD in the marrow. You cannot do that in myeloma, right? This is a much more heterogeneous disease. Who cares if you're MRD negative if you have an FDG avid bone site? You should not be even looking there. If you have paraprotein, who cares if you're MRD negative? So I think you have to be very systematic. Serologic clearance, urine clearance, radiologic clearance. Now you can talk about MRD. The only caveat, of course, is with CAR T, sometimes you can have paraproteins, but be MRD negative just because it takes a while. And the reason for that is because BCMA targeting eradicates so much of immunoglobulin, there's what's called this FC neonatal receptor, which recirculates immunoglobulin. And what that means is if you have a little bit of an M spike in a very hypogamma patient, that M spike is going to take even longer to clear because the body's recirculating it over and over. But putting that aside, let's say you have the MRD negative. This goes back to what we teach medical students, right? If you're going to do a test, you should be prepared to answer the patient, how will my management change based on the result? And I think the challenge with that, so we're trying to move away from a prognostic test, because of course MRD negative does better. We're moving away from regulatory to a predictive test, right? Which is at the bedside, how will this result change my management? And unfortunately, we don't have a lot of data yet for this predictive management. Where I'm using it is kind of the extremes of myeloma and using it in high-risk patients where I really want to make sure I'm getting to MRD negative, especially say double hit myeloma. If I'm not, I might do more consolidation. I might intensify. I might not back off on the dosing. And at the other extreme is very low-risk patients. So if somebody's standard risk MRD negative, going back to my talking about the cure, if we are curing even prior to T-cell redirection, 15 to 20% of patients, why do we do indefinite therapy on everybody? And I think there's now accumulating data. There was a Greek study looking at standard risk patients who are MRD negative post-transplant. If you're MRD negative after 3 years, and this is the other caveat, of course, with MRD, ideally, if you're going to make a decision, you should have 2 consecutive marrows, right? Because you could have sampling issue. If you have a poor quality aspirate or you missed a pocket of disease, if you have 2 consecutive marrows and you're standard risk negative, I am now discontinuing lenalidomide after shared decision making after 3 years. So induction, transplant, maintenance, MRD negatives at 3 years. I'm discussing with patient, hey, how are you doing? Do you really want to continue len? If you're having any side effects, we might stop and see how you do, because what if they're in that plateau group of not relapsing? So that's how I'm using MRD currently. But there are increasing data to make risk adapted decisions based on MRD, but I think we need more of those studies to read out.
Well, so for standard risk, after 3 years of len maintenance, MRD negative, discontinue. For high risk, MRD, if it is negative, will it discontinue?
No.
Thank you, sir. Another question is about Dara-Tech. Is Dara-Tech better than chemotherapy? Do you think it can replace the chemotherapy for newly diagnosed multiple myeloma?
Well, Daratech IVIG, I'll call it a triplet. I think based on Majestic-3, definitely is the new standard of care, right? It's hard to argue with a hazard ratio of 0.17 for PFS, hazard ratio of 0.46 for overall survival, and 90% plus dose intensity. So this means that this is deliverable on schedule and delivers PFS and OS benefits. I think the main question will be the infection mitigation strategies, right? Especially that up front. It's great to talk about being in a plateau if you didn't die, right? Like that's a big deal. And I think this is the difference between population and individual. Populations may benefit, but individual patients may die. And I think, but that's why I presented the Tecleel study. If you give immunoglobulin prophylaxis from day 1, so I think that's why I want to call it a triplet. If you give Tec-Dara immunoglobulin, I don't think you're going to see that death rate. And then I think it's a game changer. But I think that's where we really should call it a triplet and then start it from the get-go. And I think the other question is, how long do you need to continue this? And because Tec-Dara and immunoglobulin is going to be very expensive, right? Like you were just telling me about a patient who can't afford bortezomib maintenance. These drugs are going to be paralyze healthcare systems if we do 3 drugs for indefinite therapy. So I think we're going to have to do more thoughtful dosing strategies, maybe monthly earlier, maybe stopping some people. I don't know that you need 3 years of this drug because you heard Limitech, right? If you can stop after, if you're using combination and getting great responses, maybe you don't even need that 3 years. Maybe 1 year is enough. I don't know. I think those are the studies that we need to now think about. But I definitely think it will displace chemotherapy, and I have a feeling it'll also move to frontline very soon because it's hard to argue with flat lines.
True, sir. Thank you so much. Another question Dr. Shyam has. Do you think all relapsed extramedullary multiple myeloma should be treated with teclistamab plus talquetamab combined rather than single agent?
Yeah, it's a great question. I didn't present it here because it's already been presented, but there's New England paper, Redirect Tech plus Tal. First, there was a phase 1 study. Now there's a dedicated phase 2 that was published by Shaji Kumar showing great results and the best probably PFS we've seen for this combination. I think if you can do it, well, first question is the patient CAR T eligible, right? Because I still think that I would do CAR T first if I can, because you saw in CARTITUDE-1, there was that cohort of patients that didn't relapse. But I think if you don't have I know you don't have cell-to-cell, but if you don't have a study and you're going to bispecific, then I think probably this is the group that does better with combination. But again, it goes back to cost. And I think the other unanswered question right now is if you do tech PFS monotherapy, let's say, is about a year, maybe a little less for EMD. If you then do talquetamab after that PFS of talquetamab is probably around 4 months. So 12 plus 4 is 16 months, approximately, obviously. Now, what about if you do Tal-Dara? So we just published in TRIM in Blood this year. Tal-Dara is a PFS of over 20 months. And in prior bispecifics failure, it's 15 months. So now Tal-12 plus Tal-Dara 15 is 27 months. Maybe EMD is not going to be as good, but that's another option, right? It's off-label because it's not yet randomized phase 3 data. But to me, this is the sequencing issue that we need to talk about. So I've told you that Tal followed by Dara is 16. Tech followed by Tal is 16 months. Tech followed by Tal-Dara might be 27 months. What if you do Tech-Tal and you get whatever number of months you have? What do you do after? Because you've now used up both antigens. So I think what my gut would say, the more high risk the patient is, the more rapidly progressing, the bulkier the disease, the more ISS stage, the more I would do Tech-Tal combo, because you can't assume that this person will be able to get to the next line of therapy. The more single-sided EMD, favorable disease, low ISS, not much other bulky disease, maybe radiate and do tech, and then you could do Tal-Dara as the next line of therapy.
Thank you. So this brings very clear that for extramedullary disease, the sequence should be like CAR-T first, followed by Tal-Tech, followed by the sequence should be the Tech, and followed by the Dara-Tal.
Right.
Am I correct? What about plasma cell leukemia?
Plasma cell leukemia is unfortunately not included in a lot of these clinical trials, but I would say and first we should distinguish between primary and secondary and the definition. It used to be 2,000 per microliter, but now, I mean, it used to be much higher. Now it's 2,000 per microliter or 5%. If it's newly diagnosed, often these patients, if you give them induction, transplant, maintenance, their plasma cell leukemia becomes an inactive issue. It's a history of plasma cell leukemia. And so those you can follow the standard myeloma guidelines. If you have a patient who's now having secondary plasma cell leukemia and it's in the relapse setting, then try to still debulk the patient as much as possible. It didn't come up in these talks today, but in general, when you look at T-cell redirection, whether it's CAR or bispecific, more bulky disease is correlated with worse outcomes, right? So marrow is greater than 60% tend to have With CAR T, more toxicities. They tend to have less efficacy. With bispecifics, they tend to have less efficacy. Probably has to do with the tumor to effector ratio, that the more tumor you have, the less T cell activation that adequately targets the whole disease. So if you can, with a plasma cell leukemia in a relapse setting, this is where I might still use a 96-hour infusional regimen like VD-CEP, VD-PACE, knock the disease down, and then you can follow up with CAR T or bispecific to keep that going. Again, preferentially CAR T because of the treatment-free interval. And also the issue is, just to remind people about the sequencing, cilta-cel's PFS initially was 3 years, but if you do it after a prior bispecific, it's 5 months. And it was a small data set, but that's what we have. And in fact, we didn't talk much about it. Belantamab, is that available in India or not yet? No. But belantamab, which is an ADC, also compromised cilta-cel's PFS to 9 months. So I think if you're going to do a CAR T, you should do it first in a BCMA naive patient. And it's going to affect the next BCMA product, but I'm not sure that even talquetamab might not affect it because, look, if tech, as I told you earlier, if the PFS goes from 12 months to 4 months, even when you switch the antigen, I don't know that antigen switching is enough. So I would even avoid talquetamab prior to CAR T. So I do think that the sequencing is going to be more important. But in plasma cell leukemia, I would just say debulk and try to do CAR T first.
Perfect. Thank you so much, sir. Another question is from Dr. Shyam. Some patients with genomic high risk multiple myeloma and some with early relapse refractory multiple myeloma, they respond very well to bispecifics. Then how to define and decide about the high risk multiple myeloma for bispecifics?
Meaning bispecific versus CAR or within the bispecifics? I'm not sure. What was...
candidates who are high risk multiple myeloma who should be subjected to bispecifics early on?
Well, I mean, I think I would say if you're based on Majestic 3 data, I don't think it matters what the risk of the patient is. Everybody should be getting it, right? Like, so that's where, in general, if you have an active therapy, use it for everybody. Don't save it for one particular group. The only time we would do that is toxicity. So you heard me with the CAR T, for example, because of that treatment-related mortality, the secondary malignancy, SPM, neurologic, that I can understand maybe reserving it for high risk in first relapse, but I still do CAR T even in non-high risk if they're at their second relapse, right? Like if you've exhausted all the drugs, it's still the single best product. But when you apply that principle to Majestic 3, why would you not give it to even standard risk, right? Use your best therapy for every patient, get plateaus for everybody, because we need to do that to get our PFS and OS curves to start looking like lymphoma.
True, sir. Thank you so much. Another question from Dr. Sumit Milk. He is a patient of translocation 1114 multiple myeloma, given DVRD, followed by autologous stem cell transplant. Sorry, the question is translocation 1114 myeloma, DVRD followed by autologous stem cell transplant versus VRD followed by autologous stem cell transplant. So do you believe that addition of DARA adds any benefit to translocation 1114 subset?
Yeah, it's a great question. You know, I think generally it's probably something that needs to be explicitly studied, but what I can tell you, venetoclax is our best example of targeted therapy in myeloma, right? And it's been a very hot mess. First, Bellini showed that the addition to bortezomib dex with venetoclax improved PFS, but not OS. But that was because of the infectious complications. And it didn't have that signal in the non-1114. But then Canova, venetoclax dex versus pom dex, no significant difference. And there was all this talk about censoring and off-label therapy. But I'm like, come on, if this drug works so well, why is it so complicated to get approved? The addition of venetoclax should give you response rate higher, PFS higher, OS higher, shouldn't matter what the subgroup is, shouldn't matter what the control arm is. It should just be, and I think what we're learning is 1114 is probably a heterogeneous group. Some of the patients, for example, at my prior institution, we found that if you have 1114 with concurrent chromosome 1 amplification, those are the patients who don't do as well with venetoclax. And you really need to do PI, because remember, chromosome 1 has MCL1 amplification. So BCL2 and MCL1 may be like offsetting each other. So you have high BCL2, but if you also have high MCL1, you need to knock both down to really do it. Otherwise, you're just taking one, pushing one accelerator. So I would say, based on what we've seen, combination strategies seem to be the way to do it with venetoclax because you're hitting it from multiple clones. So I do think personally that we should be using quadruplet induction with these patients. The hope is that you would chip it away. But what we saw in MIDAS was that even with quadruplets, and this is now coming up over and over, even with quadruplet therapy, 11-14 patients were less likely to be MRD negative after induction, less likely to be MRD negative after transplant, but overall they'll get there. So I tell patients, look, if you're MRD negative, this is like the turtle versus the rabbit. You're not going to get there as fast. You'll get there, but you're going to be fine in the long term, right? But so we shouldn't kind of like freak out about this. And that's why that even that data set I showed you from the Emory group and Greek group, like 11-14 is one of the risk factors for having suboptimal response, but it's not conferring negative overall survival impact. So slow and steady wins the race.
Thank you. Another question is from Dr. Sumit Milk. In Majestic 3 study, the median time to CR in tech arm was 6.9 months, which is same as DPD arm. So isn't this much time unusual compared to what is seen with bispecific monotherapy?
That's a great question. I predict that if a bone marrow had been mandated at 3 months, you probably would have seen MRD negative already. And this goes back to that half-life issue of the monoclonal protein. So if you have we saw from, actually, you can see in the French study, the light chains could plummet immediately. It's the M spike that's delayed. But technically, because of our myeloma conventions, you can't call somebody an CR if they have circulating paraprotein. So anybody with an IgG isotype, which is 60% of myeloma, IgA isotype, less common, but if you have a heavy chain component and your IFE remains positive, you will not be coded as a CR, regardless if you're MRD negative. And so that's, I think, what's behind that delayed CR.
Thank you, sir. Another question from Dr. Sumit Milk. Is there any randomized data of VRD or VRD light versus DRD in transplant ineligible patients?
Those studies are going on. And I think in a way, the benefit study is the ESA VRD light because it's weekly versus VRD. And it's showing benefit with the addition of the bortezomib. But I think personally, we need longer follow-up. I don't know how much PI you need for how long to improve upon Maya, right? Because I think if you all agree, Maya showed DRD beat RD by response, PFS, and OS. It's deliverable. It's once monthly dosing in the long term. It was a median age of 73. PFS of 5 years is nothing to sneeze at for an older patient. So why are we torturing people to do better than that? So I think it has to be very clear and compelling data that you need the PI. And that's why I told you my kind of approach of it's either here nor there. I'll just follow the DARA schedule and give them Velcade if they're getting it DARA. I don't know that we need to bring them in on every other visit and for 18 months to get this theoretical benefit and give them neuropathy and transportation. We didn't talk about it, but there's increasing discussion about time toxicity. What time are we now taking away from our patients to get all these therapies? So as our results get better and better, we should be thinking about quality of life and time toxicity, all of these other options as well.
Thank you, sir. Another question from Dr. Saurabh Pandey. He has a 25 years male patient who has ECOG performance score of 1, primary refractory plasma cell leukemia with mutations commonly is IRID1A and NRAS mutation with high risk cytogenetic abnormalities, received quadruplet therapy with DARA-KRD with weekly oral cyclophosphamide for 8 weeks. Now, what should be done in the next line of therapy?
CAR T is, I think, the best shot. Now, I know you have studies, but this person really should go to a study. The other option would be, I think this is the fun part about talking to people outside of US. So in US, we don't do allo transplants, right? Because the studies have shown in head-to-head study, auto versus auto-allo, there was no difference in efficacy. But I think if you're in a resource-constrained area where you don't get access to everything you need, I still think there's a role for allo in younger patients globally, not in Western Europe and US, because doing an allo might complicate the CAR T stuff. Although we actually, cilta-cel, CARTITUDE-1, I did have some patients who had a prior allo do CART1 and they did okay. The challenge, of course, is, the T cells are you modifying, or whose T cells are those? But I think as long as they've engrafted well, there's no reason why you couldn't do it. But I would say if you don't have access to CAR T, because of the exceedingly young age of this patient, whose lifespan will likely, and not only was it the plasma cell leukemia, the refractoriness as well, right? So this young patient's life will be determined by myeloma. And if you don't have access to all the therapies because of where the patient lives and or their resources, then allo might still be considerable for this patient.
True. Thank you, sir. Another question from Dr. Priyanka. If newly diagnosed multiple myeloma patient is not eligible for transplant, then will you choose triplet or quadruplet?
I kind of alluded to that. I would say for non-transplant, I usually would say DRD for everybody, and I will give the PI on the DARA backbone for following types of things: high risk, suboptimal response, very fit patient, no history of neuropathy. If, on the other hand, they're more frail, not high risk, they have neuropathy, I won't do the quad. I would just do DRD. And very important, I think, to this point, if you're saying somebody is kind of on the frailer side, I just remind people, please take time to calculate the creatinine clearance for lenalidomide, right? Because often the person's creatinine is normal, but if it's a small elderly female, her clearance is probably significantly impaired. And we should not be using lenalidomide 25 milligrams in these patients, right? And the more frail and old the patient is, the more you should reduce the lenalidomide. And same thing for the DEX. No one above 70 should be getting DEX 40, should be 20 milligrams. And we should be mindful of reducing those even more. Because I think, to me, for older patients, it's not the number of drugs, it's the dosing intensity that really matters more. You can do triplets, right? The triplet is not more toxic than doublet. But if you give, I would say, if you gave full dose Len 25 and Dex 40, that's going to be much harder on a patient than DARA with Len 10 milligrams and Dex 20 milligrams, right? 3 drugs can be actually very well tolerated. You just have to be mindful of the dose intensity. And along those lines, bortezomib, I would never do twice weekly. I personally would not have enrolled any of my older patients in Cepheus and Imraz. I'd be like, this is stupid. Why are we doing this study? Just do weekly, right? Like, I think, and there's a precedent for that because Alcyon did DARA VMP only twice weekly for the first cycle. I could do that. But otherwise, what you're basically going to do with these studies is you're going to have these older patients do these studies, wait for neuropathy, then you hold, reduce. How are we helping patients by doing that?
True, sir. Thank you so much. Another question from Dr. Sumit Mirk. In your practice, for a patient who is MRD negative and in CR on teclistamab and tolerating very well, will you, and how long do you continue teclistamab?
Oh, that's a great question. I will start with that first premise is not always there. So I have stopped teclistamab in 2 or 3 patients, but some of them is because despite immunoglobulin replacement, they kept getting respiratory infections. So they weren't severe pneumonias, but one pearl I've learned is whenever somebody gets labeled with COPD in their late 60s and 70s as a non-smoker, which one of my patients got this label, it was really bronchiectasis from recurrent lung damage, right? So let's not call myeloma patients on BCMA bispecific COPD that's treatment emergent when it's likely recurrent infection. And so you're seeing that these little respiratory things over time can damage lungs. So, but let's take the presumption that the patient doesn't even have that. But I just want to point that out, that itself may not be the case. So I stopped it in those patients, and also partly because, I moved from New York to UCSF, so it's been 2.5 years ago. Some of those patients were very fit patients that did not get CAR T, and I didn't I wanted to stop it because I was hoping that maybe with a long washout, I could do CAR T. So those patients, I did take one person to CAR T. She took about 1.5 years to relapse off teclistamab. And then we've done the CAR T. She's doing okay so far, so we'll see. But she was having recurrent respiratory infection. I think where I would then make this decision point is there's the MRD negative CR as part of the equation, but what about the other features, right? So what's the fitness of the patient? What's their ISS stage? Do they have extramedullary disease? Do they have high-risk genetics? If all of those are negative, then I think there's a shared decision-making again with the patient. You could say, look, based on emerging data, we may be able to stop it safely. We still have to continue the immunoglobulin. And if you want a treatment-free interval from the tech, we can try that. But with the caveat that we probably can't use it very well if your myeloma comes back. So either use it now or probably it's not going to do. You can still try it again. It's not like it's off label, but that's the thing. So I think when you have that discussion with patients, I have a feeling some patients might say, I'll just keep it going. I'm tolerating it well. Others might say, well, if it's going to be just as good off it, I'll stop it. Why do I need it? And the payers may have a take on this, right? So insurance and cost.
True. So, for example, if you stop teclistamab and you plan to go for CAR T cell therapy, what is the time duration between the two? For
I
stopping
have no answer. I don't have good prospective data for that, right? But I only did that in this one patient because she was getting all these infections. And I was like, she'll do better with CAR T. At least it's a finite duration. And she keeps getting these infections despite immunoglobulin replacement. I have to say, I haven't done that in many patients. That was a unique patient. I don't even do that after talquetamab, as I allude to, because I do think that the T cell exhaustion phenomenon is real. And the fact that, and also BCMA exposure is real. Like the fact that even belantamab's PFS with subsequent cilta-cel went down from 3 years to 9 months. I think if you give a BCMA-directed therapy, it will affect the next BCMA therapy. So I'm not sure for most patients I would do a CAR T after bispecific, just because it's a lot of cost, expense, and hassle to get a short PFS.
Thank you. Another question from Dr. Sumit Mid. Do you cytoreduce even before using teclistamab therapy? And if yes, in which scenarios and with what?
I have done it in very bulky disease, like, or rapidly progressing disease. Somebody with like certainly plasma cell leukemia, bone marrow like 80, 90%, bulky extramedullary disease. I might do the VD set, VD pace. One of my former fellows who's now an attending at Princess Margaret in Canada, they presented data at last year's IMS meeting 2025 in Toronto. And they showed that the debulking of myeloma prior to bispecific seem to yield better results. Again, going back to that tumor effector ratio, I think if you have in almost every bispecific, when you look at the forest plot of subgroups, heavy marrow burden always tends to be having lower PFS, lower response rate. And so I think, and there's also some preclinical data and I think leukemia data that debulking gives you better bispecific activity. So I think if it's very bulky disease, I do it. But I've also had patients where one person where I was trying to do it and it didn't really, I think he had, I'm trying to remember, I think he was getting rapidly progressing disease, got tech, had progressed, and I was trying to give him 96-hour infusional chemo debulking to TAL. The 96-hour chemo didn't work, but then the TAL worked. So, so it's not that it's going to, you can do the best you can, but ultimately you're going to still do it anyway, right? So I think if you have the luxury of debulking and the patient's willing to, try it.
Thank you. Another question from Dr. Yimon Tent. What is your preferred bispecific? Because any difference in effect according to your experience?
I really think that with the BCMAs, Tech, Alro, Linvo, when I was at Sinai, we had both Tech and Linvo studies. I didn't have Elra exposure, but then I don't think there's a difference in efficacy. I think some of the differences you're seeing in PFS is because these are single arm studies and the newer BCMA bispecifics are learning from the earlier one about immunoglobulin replacement, monitoring for opportunistic infection, PJP prophylaxis. So I'm not sure that, for example, the PFS of 17 months for ELRA is better than 12 months of tech. I think that's just COVID pandemic and these other issues. Safety-wise, I don't think there's a difference either. I think if you're seeing different safety infection signals, it's not the target. It's not the product. It's just the immunoglobulin and supportive care. So then it's going to come down to, if it's not efficacy and safety, what other variables are there? Cost and convenience. Cost is beyond the scope of this. I think it's very regionally based. I can tell you that at UCSF, we don't have anything other than tech on formulary because the pharmacist did all the calculations. You know, in the US, they give you, for example, some drugs give you free drug for the step up because then for the admission that you do, because in the US, there's a lot of complexity of whether you do inpatient step up, outpatient step up, how is it reimbursed? But between the free drug, the dosing schedule, flat dosing versus fixed dosing, in the end, it doesn't really make a huge difference. So there wasn't a compelling cost differential. And then there's the convenience issue, right? Which I don't know that there's a big difference other than Linvo's IV, and the other two are sub-Q, so depending on your preference, and Linvo's weekly step up, as opposed to within a couple of days. For some practices, that might be better because you don't have to have the patient go as long an admission. So I think those are some of the features, but probably the one product that might be a differentiator is the AbbVie product known as Intentamig. This product was specifically chosen for lower CD3 affinity, and it's known to have less CRS and less need for step-ups. So if there's a product that's more convenient for outpatient dosing and it goes to monthly very early, that may be a preferential thing to use. But then the last thing I'll say on that is that there's a possibility that all of this will be moot because if in the future Romantamig, which is Janssen's GPRC BCMA trispecific, and that data has shown in last year 100% response rate in a median of 4 lines of therapy with very low rates of CRS. It's monthly dosing, outpatient step up, one step up, outpatient dosing. If they get to the market and they have the best response rate, PFS outpatient, that may change the whole game, right? Like, why do anything else if you can do both 2 targets, 1 step up, convenient, monthly dosing? Could be a game changer.
Thank you. And the last question is from Dr. Avinash Singh. Your treatment for CNS myeloma.
So CNS myeloma, I think we can divide into kind of different compartments. There's parenchymal brain tissue mass, there's leptomeningeal disease, and then there's myelomatous meningitis. And I think the dosing and management of drugs is very different for those. Parenchymal brain myeloma is exceedingly rare. We usually don't see that. And there you would probably need to radiate that mass, but then apply the principles of the remaining drugs. Leptomeningeal is much more common, and because we think the mechanism is that actually myeloma is in the bones, the skull has bones, and then there's dural vessels. And I think when the myeloma can escape from these vessels, you can get into the leptomeninges. And there, if it's very symptomatic, you can radiate that spot. Drugs that are known to penetrate the blood-brain barrier are pomalidomide, selinexor, melphalan, BCNU. These are the drugs that you could consider using. And I'll get back to that in a second, because if it's myelomatous meningitis, you really need to do intrathecal chemo because you have to clear the spinal fluid. So typically that's methotrexate, Aracy, and steroids. So use that triplet therapy to clear the CSF. In my experience, we've seen the best outcomes with, well, I'll divide my answer into before CAR T and now. Pre-CAR T, our best outcomes, when I was at Mount Sinai, we would do MEL BCNU salvage auto, because both, you could even actually do BEAM, because BEAM is routinely used in lymphoma. And probably of the drugs, the etoposide is probably you would reduce, but BCNU, Aracy, and melphalan are all going to be either CNS penetrating or myeloma benefiting. And so BEAM auto, attenuated BEAM, we had patients who got that were in long-term remission, then they were able to go on to other therapies after that. So it's almost like a sterilizing procedure. And then you can do CAR T, for example. And recently, I'll just mention, there was a publication, I think in Blood, showing about 14 patients who had CNS myeloma who did get BCMA CAR T. And you might worry like, oh, will these patients get more neurotox? But it seems that their AE profile was no different. And there's actually CNS lymphoma studies with also supporting CAR T. So I don't think it's an absolute contraindication, but we should do our best to try to debulk the disease before going into it, of course.
Thank you. In place of BCNU, can we use, in place of BEAM, can we use TIM, thiotype based?
I suppose so, but I think the BCNU it's actually an old drug that's been used for myeloma, right? So if you want to kill myeloma and get CNS penetration, I might lean more towards BEAM, but I personally have not used much thiotypa, but maybe if others have, that might be a reasonable substitute.
Thank you, sir. Dr. James Kungar, you have another question?
Yes, one more question. I
Yep.
just want to know whether there is any study.
Yeah, we can hear you. Please go ahead.
For to know the bone marrow immune microenvironment, so that we can know how the patient is likely to respond to immunotherapies like bispecifics and CAR T cell. About
So if I understood,
bone
there was
marrow
cutting out.
immune microenvironment in multiple myeloma patients. Okay.
Well, so let's broaden the question to, are there any predictive factors for immunotherapy responses? And I think there's
immunotherapy responses, whether patient will respond.
Right. I got
Whether
the
T
question.
cells
So
are T cells, how the T cells are.
right. So there's the clinical factors, there's the myeloma factors, and then there's the immune factors. And the short answer is the immune factors, there's no validated assays, right? So no one's running around doing T cell characterization, quantification, or functional assays. So some studies with CAR Ts do require an absolute lymphocyte count of, let's say, 0.3 or higher, because if you don't have adequate lymphocytes, what are you going to collect and apheresis and modify? So there is that kind of very low rudimentary absolute lymphocyte count as a measurement. But beyond that, we're not doing, for example, T cell profiling, looking at co-exhaustion markers. Do they have LAG3, TIGIT, PD-1? None of that's being done routinely in myeloma. When it comes to the other factors, the disease itself, the initial CAR T clinical trials would mandate a BCMA expression cutoff, but subsequently that was loosened because it didn't seem to matter. And I think what we know now is that the likelihood of monoallelic loss in a newly diagnosed patient with BCMA is very low. It's probably 1%. After a BCMA-directed therapy, it's still pretty uncommon to get biallelic loss of BCMA. And so there's the genomic is not a simple expression issue. Protein-wise, you often see BCMA expression. I think what we don't understand yet is the epitope issue, right? So the Calgary group has shown that if you may have BCMA expressed genomically, you may have BCMA expressed on the tumor, but the epitope may be modified, particularly the extracellular domain. Probably 50 to 70% of patients have mutations, point mutations in these domains that will make them less susceptible to subsequent BCMA therapy. So I think we're in the infancy. There are now commercial assays. So for example, we have one called GTC. So if you have somebody with a prior immunotherapy and you want to sequence it, you can send them the myeloma. Let's say you can do a marrow and send them the aspirate. They will tell you what is the BCMA expression? Are there any point mutations? What is the likelihood of response to therapy? Same thing, GPRC. The difference with GPRC, there's a 10% monoallelic loss at baseline. So there's a higher pressure selection for double loss at the time of progression on immunotherapy. It's still not common. I would say many patients will maintain GPRC genomic expression. Many patients will maintain protein expression. But again, a lot of epitope changes are happening that we don't fully understand yet. And then, of course, there's the immune microenvironment. So another thing that's come up is not just the myeloid in the disease, not just the T cells in the disease, but also the myeloid compartment. So Samir Parikh from Sinai has shown work that there is a protein called S100, where that S100 increase is consistent with a myeloid suppressor phenotype. And when you give preclinically, when you block that S100 with a monoclonal antibody, you're actually getting better responses. So, and there's actually a recent in Nature Cell this week, or just in very recently, the MMRF group published single cell sequencing from about 300 patients, hundreds of thousands of cells. And one of the themes that's coming up is that patients who have an inflammatory microenvironment are having worse outcomes. And I think this is probably going back to this myeloid inflammatory. It's probably why we keep seeing high ferritins are a negative predictor for immune-based therapies. And so lastly, I think because all of these technologies are their infancy, there's the clinical variables, right? Age does not seem to be an adverse predictor. In fact, talquetamab, older patients had a better PFS, and it may be because they have less ferritin actually in this one paper. So age, but EMD, high risk, bulky disease, ISS3 are all coming up. ISS3 in particular is important to pay attention to in light of your question, because it's kind of surprising. Why still such an old staging technique? Why does it keep coming up over and over? Beta-2M is actually an HLA class 1 molecule. And there are studies showing that these high beta-2M are probably suppressing the immune response in myeloma patients. And that's probably how they're linked. But more of that pathway is being studied. But those are some guiding principles. But the short answer is, if you're thinking about using an immunotherapy, it's still probably the best therapy we have, right? And if you argue, what other myeloma therapy do we have a biomarker for? Our closest was 1114, and we discussed what a complicated strategy that is. So I think, unfortunately, in myeloma, the clinical development precedes the translational understanding of how these drugs are working.
Thank you. Any other question, Dr. Khungar?
Thank you.
Yeah. So that finish all the questions from the chat box. And anybody has any other question? Well, so there are no more present signs and no more questions in the chat box. Thank you so much, Dr. Ajay Chari, for a wonderful, wonderful lecture, and what a wonderful discussion. Fantastic discussion.
Thank you so much. Thank you. Thank you.
Many doubts of us. That was brilliant. Thank you so much.
Thank you. Have a great day.
Thank you. Bye.
Thank you, sir.